All right, in this section, we are now moving into asthma. And I wanted to have an entire section just focused on asthma because it's one of the most common conditions you'll face as a healthcare practitioner with your patient population, whether they're kids or adults. And it's one of the conditions where functional medicine really shines in. So when you're looking at asthma, you're dealing with kids in the early stages, and with them, you have to really know if they get really stuck in this, starting to use the bronchodilator with glucocorticoids in early phase for their childhood, like they're going to have some lung impairment issues. They're going to have some lack of developmental issues in many different areas. It impacts growth hormone function. So it's one of the things you really want to address right away and really find the cause for it. And obviously, asthma is strongly linked with child developmental disorders, especially ADHD. There's a lot of overlap between mucosal inflammation and brain inflammation that you'll see with them. And then as people, progress throughout their life, some of those things can change, but they can also reoccur. And then once they reoccur, they're having this inflammatory mucosal response that is pretty important. So asthma is the most common non-communicable chronic disease worldwide. In the United States, it's linked with more than $80 billion in cost annually. And when you really look at what's happening with asthma, as most of you know, there's just excess mucus is a key factor in here, with this muscle tightness, this muscle spasm, and it's just this chronic inflammation of these airways where a person really has difficulty breathing. And the key factor that makes asthma so unique, that there's a trigger. So there's an obvious trigger, an allergen, exercise, some kind of respiratory infection, a stressful emotional response. But the fact that there's a trigger is a key factor in the diagnosis of asthma. So the main treatment is obviously, inhalers, which are bronchodilators and corticosteroids that are mixed together. And when it comes to the diagnosis of asthma, there's two things that are necessary. One of them is non-specific respiratory signs and symptoms like wheezing, coughing, intermittent dyspnea. And then there has to be a demonstration of expiratory airflow obstruction. So a reduced peak expiratory flow, you can measure with the spirometer or with the peak expiratory flow device. We'll go over that in a second if you're not familiar with it. And decreased forced expiratory volume in 1 second, or reduced FEV1. So the combination of both of these are necessary for asthma. And then also, another major clue is that, again, there's some trigger that sometimes will cause these asthma attacks. Sometimes it's obvious. Most of the times it's obvious, but not always. Key concept. Physiologically, asthma is characterized by bronchial mucosal hyperresponsiveness, the tendency of airways to narrow excessively in response to a variety of stimuli that provoke little or no bronchoconstriction in a person without airway disease. So it's very clear when they look at the epithelium or the microbiome of the upper respiratory tract and people that have asthma, it is different than a healthy population. There is dysbiosis in the mucosa, and there's a lot of inflammatory mediators that are there, and there's this tendency and this proneness for these cells to have a hyper responsiveness to any kind of allergen or airborne response. Now, when you're working with patients that have asthma, you want to make sure you clearly define what the clinical goals are when it comes to their management. So one goal would be just to control their asthma symptoms. And when we say control their symptoms, whether it's difficulty breathing or wheezing or chest tightness or cough, it's to reduce the frequency and intensity of their asthma attacks. Maybe you completely resolve it, but just the fact you can reduce the frequency and the intensity is really a clinical success. You want to really make sure you have set goals that are realistic when you're working with a patient with any kind of condition. So if you can focus on not complete eradication, but reducing the frequency and intensity of some of these asthma symptoms, that will be very important to keep the patient motivated and also yourself motivated. Identify and remove triggers. So it's going to be different for some people versus others. Exercise is a specific form of asthma where they have exercise-induced asthma. This is a huge indication that they have excess free radicals. It could be any type of allergen. The allergens could be something that's a common allergen in their home, or it could be some type of special grass or seed or something that's in the environment that they're getting used to. Many asthmatic patients are very sensitive to secondhand smoke. Air pollution could be a factor, and you can download apps that will show you air pollution in a person's region. So you also want to have some of your asthmatic patients download some of the public information of within their zip code, what's the air pollution like, and see if they can make any association between the air pollution and their severity of asthma. And then some people have unique forms of asthma where excess hot or cold exposures can trigger their symptoms. And when you look at like what triggers the need for antioxidants, and we talked about this earlier, is things that activate hormesis. Hormesis is a challenge to the body. So cold, hot, and exercise are really ways where you can turn on your own antioxidant system, but you have to have precursors there. So if you have a child that has no precursor like N-acetylcysteine or micronutrients or sulfur in their diet, and then all of a sudden they exercise and have excess hot or excess cold exposure, and that would normally trigger the body to turn on antioxidants, they don't have them, it's not uncommon for them to have significant attacks. So airborne chemical irritants, stress is another known factor that can trigger asthmatic responses, and that is obviously associated with HPA axis, lung gut axis dysregulation. So, you want to identify removing the trigger that's specific to the patient. Participate in normal daily activities could be another really goal without limitations to breathing, whether it's sleep, work, or exercise, and then reduce requirements for medications or hospital visits. And so these are things you want to like really establish in the very beginning with your patients that are dealing with asthma. Now, when you do a clinical history, there's some really important questions to help identify asthma triggers. So I made a list of these, and you can even use this as a guide as you're working with your patient. Go, let's try to find some triggers together. Let's first look at the symptoms associated with airborne allergen triggers. Are your symptoms worse at various locations? Like they may notice when they go on vacation, they're much, much better. Their asthma attacks are much, much better, and they think, oh, it's just the stress of, the lack of stress of being on vacation, but in fact it's really because their house just has so many airborne irritants in there, and whether it's dust or mildew or other things that are really triggering the response. Do you notice nasal irritation before asthma attacks? That's a major clue that they're getting their nasal mucosa activated, and that there really is an airborne trigger that's causing that. Do common airborne allergens such as dust, pollen, mold cause reactions for them? Does mildew or pets trigger your symptoms? Those are really important as well. Oxidative stress triggers. Are your symptoms made worse with exercise? Are your symptoms made worse with poor air quality? Do the smoke or other chemical irritants trigger your symptoms? Are your symptoms made worse at certain locations? Those are related to oxidative stress, and even hot and cold changes that cause symptoms could be associated with oxidative stress. Dietary protein triggers. Are your symptoms made worse or better with your diet? Do you notice any foods that flare up your symptoms? And then loss of stress resiliency. Does stress flare up your symptoms? Does lack of sleep flare up your symptoms? Do you notice your symptoms are worse if you're overworked or overtrained? Now, listen, if someone has like airborne allergen triggers, you immediately need to like really start looking at their lung gut access, but also maybe start looking at airborne allergen panel. If oxidative stress triggers are a key factor, you definitely want to look at what could be depleting their antioxidants. You want to experiment and dose the antioxidants as much as you can, and then obviously the same with food. And if stress resilience is an issue, then you really got to figure out how they can exercise, get some social interaction, get some sleep, and really consider clinical strategies like using adaptogens and just general blood sugar stability throughout the day to really reduce that loss of stress resiliency. Okay. Key questions you should always ask when you're working up your asthma patients as you're trying to find out mechanisms to go after. Is there anything that flares up or intensifies your asthma? Those are always clues of what mechanisms are involved and also what they need to reduce as they're trying to recover. And is there anything that helps your asthma symptoms? So those two can really immediately start to help you draw out a plan. The patients will tell you like, yeah, I noticed when I was taking green tea regularly, I felt better. You're like, okay, great. You should be taking green tea. Oh, you think I should? Yeah. How often? All the time. Just if you notice, you have to say like, listen, clinically, we're searching for these. When you've already found them, like we need to use them. And that's so, silly to think about, but that's actually what happens in practice. Now, when you're looking at the severity of asthma, there's a whole lot of factors that are involved. So, mucosal health, obviously, is one of the key ones. Predisposition to allergy, atopy. And this is associated with some genetics that are very unique to developing asthma. Environmental triggers, antioxidant status, lung adrenal access, pre-existing endogenous source of inflammation, respiratory mucosal dysbiosis, gastrointestinal dysbiosis, loss of immune tolerance, airway hyperresponsiveness during mucosal development. This is something you have to find out from their history. But these are all key factors. And with all these respiratory conditions, there's a lot of overlap between all of them because they're all involved with this respiratory mucosa. This one right here, you don't want to overlook. So we talked about this critical period of immune priming with, I think, the introductory lecture where we went over some research. And there's this critical window of time from perinatal, but especially from birth to the first few years where the mucosa system is developing. And if there's a lot of stressors to the mucosa, like lots of antibiotics, and there's a very poor diet, lots of a pro-inflammatory diet, if there is formula fed instead of breastfeeding, you can have a person that has their immune system just develop hyperresponsiveness for the rest of their life to some degree. And you just need to be aware of that in the history. And if that is part of their medical history, then you need to know your prognosis may not be as responsive to some of the things to do with dietary and lifestyle that other people might respond to. The other key thing that you're always looking at with all respiratory conditions and asthma is, what is their pulmonary resiliency? This was a fundamental concept that we went over, but are their SIGA levels intact? We can measure those. Do they have pulmonary barrier permeability? Do they have enough antioxidants? Do they have excess mucus and are not handling that very well? Do they have mucociliary clearance issues? Is their lung access dysfunctional? Do they have systemic inflammatory immune responses? What's going on with their lung adrenal access? So these are ultimately these variables are the things we're trying to look for and find clues that we may need to support. And sometimes you don't even treat the asthma. You're treating other things with the patient's chief complaint. Like they have insomnia, and you find out that they have nocturnal hypoglycemia at night. So you basically go, let's just focus on getting your blood sugar levels stable, and let's see what happens with your asthma as you do that, because that can help rebuild the adrenal axis. So the lung adrenal axis can rebuild as they're actually not waking up in the middle of the night with nocturnal hypoglycemia because they ate some protein before they went to bed and maybe started to stabilize their blood sugar levels. So, that's the clinical application of some of this information. Now, when you're looking at asthma, you want to get an idea of what if they have mild, moderate, or severe asthma, the classification of their asthma severity. And it's really based on how many symptoms they have and what it takes to control their symptoms. So mild asthma is defined as minimal symptoms and few risk factors that cause exacerbations, and symptoms are managed with bronchodilator inhaler with or without low-dose glucocorticoids. So that's mild asthma. And moderate asthma is defined by asthma controlled by bronchodilator and medium-dose glucocorticoid inhaler. So they need more anti-inflammatories. And then severe asthma is defined by asthma requiring bronchodilator inhalers with high-dose glucocorticoid inhalers or uncontrolled asthma despite these therapies. So when you look at the conventional treatment for asthma from mild, moderate to severe, if they have mild asthma, they may just be given a short-acting beta-agonist bronchodilator without any glucocorticoids at all. Just if they can bronchodilate, does that make any difference for them? And that would be ideal because you don't want a person to start getting exposed to glucocorticoids even at low doses on a regular basis. And somewhere between mild to moderate, they start to add in the low-dose glucocorticoids in with the bronchodilator as a form of therapy. This will just be in the inhaler itself, depending on what's prescribed to them. And then as they get into severe asthma, they're getting the bronchodilator, the inhalers with much more higher steroids. They may be even given other types of glucocorticoids, like through a nebulizer. And then there are some patients that just will not respond to bronchodilators and glucocorticoids, and this is the most severe form of asthma, and this is like the drug-resistant non-responsive asthma. And for these patients, they're going after the immune system very aggressively. So they may use like anti-IgE monoclonal antibodies to stop their immunoglobulin IgE reactions. They may use anti-eosinophilic therapy, and they'll usually do this if their eosinophils are very, very high. They might use monoclonal antibodies. It's like IL-4, IL-13 monoclonal antibodies to just have have blocking of their immune response. They might use anti-thymic stroma or lymphopoietin therapy, which basically has an impact on thymus immune reactivity and responses. And here's just a diagram chart of the conventional model that's used with very severe asthma. But it's basically biological agents that are there to shut down the IgE allergy immune response, because they can't do it with glucocorticoids alone. So they have to be much more specific. Okay, and these very severe asthmatic patients have already gone through years and years and long periods of time of being on high dose glucocorticoids, and they have lots of effects of their microbiome being disrupted, their gut barrier, lung barrier being disrupted, suppressed SIG A cells. So they're when you get them in your practice, there's a lot of work to do over a period of time just to get their general health improved. Now, one of the things that is really important to do with your asthmatic patients, and you can also do these with any one of your lower respiratory-based conditions, like a patient that has chronic bronchitis, is to use a peak flow meter. And a peak flow meter is something that a person can purchase like off Amazon or online anywhere. They're like around $15, $20, not very expensive. And it's basically like a spirometer that just measures only one thing, which is their expiratory output. So basically you have the patient get one of these instruments, they put their lips around there, they take a deep breath first, they seal with their lips, they blow out as hard as they can, they repeat this 3 times, and then they look at their best of 3 reading, they record that, and then they can monitor that throughout the day. So this is really looking at their peak expiratory flow, and it's a good indication of what's going on. Now, these peak expiratory flows are always, the range is always determined by a person's age and height and sex. So there's different charts that they can use to kind of see where they are with them. And then tracking these throughout the day would be really, really important to find trends and to see if the various types of treatments are working. So this can be done, again, for not just asthma, but things like chronic bronchitis or emphysema. And they can, have a note of what the time was, if they took any medications, any supplements, before and after the type of therapies. And then they can maybe start noticing a trend where their expiratory volume is less. You can start correlating that with exposures to various airborne allergens or environments or foods. But this is very nice, because sometimes it's very hard to determine some triggers with asthma unless you have symptoms. Now, instead of getting the peak flow meter is very easy and inexpensive to use, but there's also the possibility to just get a spirometer. And as a practitioner, you should have a spirometer in your office, always, because this is critical for just looking at general lung function. But there are these portable spirometers. Now you're talking about anywhere between $200 to $400 that can link to apps, which then can monitor and track a person's output throughout the day. And these, in addition to measuring peak expiratory flow, they can also measure the forced expiratory volume over 1 second, and they can map those out. And this could be a good way to monitor and track patients if you're trying to see if the interventions that they're doing with diet, nutrition, lifestyle, or with medication is having some type of an impact with them. Now, a lot of times you can do a baseline, like if you have a patient that comes into your office and asthma is their chief complaint, maybe you order a bunch of lab tests before you start anything. You can say, if you haven't been monitoring your peak expiratory flow, let's monitor that for the next week or 2 before your labs come back. That'll be your baseline, and then you can do some interventions and see if you can make some change with that. For most people, the the basic peak flow meter is the easiest way to do it, but it is nice to have these graphic representations if they're a little bit more tech advanced to do this. Okay. Now, there's certain key things that are important to understand about asthma. The microbiome is obviously directly linked to this. This is so prevalent now in the literature. This is just part of mainstream pulmonology literature of how important the microbiome is, and it's linked to asthma, and especially in early life where the microbiome is developing. So let me share with you a key study here. This study is in your notes. And this actually starts with the microbiome developing in very early stages, even in prenatal stages during pregnancy. So in this paper, they go on to conclude that the maternal gut microbiome plays a fundamental role in priming the infant's developing immune system to acquire immune competence and regulation following exposure to the extrauterine environment. Evidence from a diverse range of studies suggests that loss of ancestral gut microbes and altered metabolic activity of maternal microbiome may be contributing to the high rate of allergic disease and asthma in the modern environment. So, there's this old model of when you're pregnant, if you crave Rocky Road ice cream and pizza, you should eat it because your body's telling you need to do that. No. Is absolutely not the case. More and more research shows the mother's microbiome health has a huge impact on the child's health, their neurodevelopment, and also their general immune priming and so-called function. We went through a lot of these studies in the infertility course. We really spent a large section or a specific lecture, I should say, just focused on perinatal care and nutrition and what that does to pregnancy risk and also for the child's outcome. So we know with mothers that just ate poorly and didn't have good microbiome health during their pregnancy, that could really put their child at risk for developing allergy and asthma throughout the rest of their life. And this is another paper that was published called Asthma, the Microbiome Defining the Critical Window in Early Life. Animal model research supports the role of the microbiome in asthma and atopic disease development. Further, these models have identified an early life critical window during which gut microbial dysbiosis is most influential in promoting hypersensitivity disorders. So you can see here this window of opportunity from conception to a few years after, let's say the first 18 months after birth, is this window of opportunity. And protective things like breastfeeding, where a person has lipopolysaccharides and different immune modulating peptides and immune support to really support the gut is critical. You just cannot replace that with formula. And the child or mother are not exposed to high doses of antibiotics, and they're getting lots of vitamin A and vitamin D and healthy food throughout their diet, and their diet is diverse. Those key factors can impact this window of opportunity for how well their microbiome will be for the rest of their life. And there'll be some people that you'll find will always have to take that probiotics or other digestive support products or fibers just to function normally. And why do they have to take this forever? Because their immune system has been primed. It's been different. They have a hyper-responsive mucosal system at this point. Just ways some people develop their immune system. Okay. This was another paper. It goes on to show that the only interventions to prevent the development of asthma include a multifaceted intervention with prolonged breastfeeding, delayed weaning in infants, and an elimination of common food allergens until 12 months of age, and those at increased risk for asthma. So this even goes for the mom. If the mom knows they can't really tolerate certain dietary food proteins, and they can optimally breastfeed for a long period of time. The longer they can breastfeed, honestly, I think the better. I think most of the studies that we reviewed in the infertility course were for at least 18 months would be important. There's also studies we reviewed in the childhood developmental disorders course for the Crosby Institute where there was a complete change in outcome of kids with autism and ADHD if that was directly related to how long the mother breastfed, because even some children as they're developing during fetal development, they can get some neuroinflammation. One of the things that breastfeeding does, it provides these very powerful immune modulating peptides and polysaccharides that can change their immune system during those early stages of immune and neurodevelopment. Now, this is, an illustration of like what's happening here. If there's breastfeeding, if there's a maternal vaginal microbiome, which is preferred to C-section, if there's antibiotics involved or not involved, these things that eventually impact airway dysbiosis. And if their airway dysbiosis and their immune system is primed differently, they get a skewed immune response and develop hypersensitivity to airborne allergens that most people won't have with the same amount of trace exposure. And this leads to like the asthma pathophysiology. So here you can see in this illustration here, like the worst scenario to promote asthma: C-section, formula-fed, lots of antimicrobials, urban microenvironment. These things increase risk for a person to develop asthma throughout their life. Okay. Now, this was a study that was done called Maternal Dietary Inflammatory Potential and Quality Associated with Offspring Asthma Risk. It was a 10-year follow-up study. They looked at 862 mothers, and they concluded that our results suggest that a pro-inflammatory and low-quality diet during pregnancy is associated with a higher risk of offspring asthma. So there's probably never a point in a woman's lifespan where they need to eat the best they've ever had in their life, and it's in that perinatal period of time, and also after they give birth, because you want the breast milk to be as healthy as possible when they're nursing their child. Okay. So this is a diagram that really shows mother-to-child transfer protecting agents for allergic airway inflammation. Breast milk has IgA. They also have various things called tolerogenic factors, which make the immune system not as reactive. Gut growth factors, microbiota influencing factors that all impact the development of the gut and respiratory mucosa. A common feature of asthma that is well understood at this point is this dysfunction in this lung-gut axis, or lung microbiome dysbiosis and gut microbiome dysbiosis. Now, you should also be aware that it's not just the gut. The nasal mucosa has a significant impact on asthma control as well. So this was a study that was published. Nasal bacterial microbiome differs between healthy controls of asthma and allergic rhinitis, and they found lower evenness and richness in nasal microbiome may increase the risk of poor asthma control in patients with asthma and comorbid allergic rhinitis. So it's really a combination of the gut microbiome and the nasal microbiome really having strong influences in the pulmonary mucosal microbiome that then impacts the expression and severity of asthma. And here they're really showing some studies here with different populations with the normal healthy nasal microbiome, and air pollution is one of the main disruptors of the nasal microbiome. Indoor allergens is a key factor, and very clear indications of this diversity in the bacterial species. Now, the bacterial species in the gut are going to have a significant influence in the bacterial species in the respiratory mucosa and in the pulmonary mucosa. And consumption of fibers like short-chain fatty acids fuel the diversity of populations in the pulmonary microbiota and the nasal microbiota. So you really want to encourage patients to have a rich, healthy, diverse diet. The problem you get is you get these asthmatic kids, and they're like, what do they eat? And they're like, they just eat mac and cheese and pizza, just like kids with learning disorders. We got to change that. We've got to change their microbiome, and it's not going to be enough just to give them like a gummy probiotic to do that. You're going to have to make some significant change in their diet to get those patterns changed. And there's these direct relationships between how much diversity they have of their gut bacteria and how severe their asthma expressions are. So, it's pretty significant. Now here you can see an illustration here of shifts in the microbiome functions and metabolic processes, like from early birth all the way to adulthood, through different stages of puberty and adulthood. This initial critical period of time that you can see again listed in this illustration from birth, it's really perinatal to the first 18 months. They're listing it at 3-month to 12-month window, but this is like an ongoing concern for some of your patients. You want to always look at their history and see if they've had a history of long, if you see a history of a person that's ear infections for always, asthma as a kid, allergies forever. They were getting allergy shots all the time. They're always on inhalers. They probably have damaged their immune system in that critical window. I would just say damaged. They've probably turned on their immune system to a hyper-responsive state during that critical window, and they're going to be dealing with these things all the time. And they really progress into the patient that it's basically reactive to everything. And then, you can do the best you can with that nutrition lifestyle, but it's never, it may not be enough to completely dampen their hyper-responsiveness. So you just do what you can do to improve quality of life, and you start to make peace with that realization so you don't completely burn out doing all working with them. Now, there's some strong relationships between blood sugar control and asthma. So just make it simple. Like, you get a kid with asthma, you get an adult with asthma, make sure the gut's healthy, make sure they're not eating inflammatory food, make sure they don't have any gut infections, all the concepts that you know how to apply to improve a healthy gut, and how to evaluate gut dysfunctions is be critical working with asthma patients. If you want more of that information, not familiar with that, if you're new to functional medicine, we have an entire course on the gastrointestinal system at the Crohn's Institute. All those principles would be immediately implemented to optimize the microbiome with anyone that suffers from asthma, to try to improve that gut access to the lungs and to the respiratory mucosa as well. Okay. Now, an overlooked area that is really critical for asthma is blood sugar stability. So, if you look at some of the research that's done, they know that when people get into hypoglycemic stages or when they get insulin surges, this aggravates asthma symptoms. And if their adrenal cortisol output is low, they also have increased expression of asthma because the adrenal glucocorticoids dampen the inflammatory response. So if we look over here, this is a study where they looked at the adrenal response, and they found that there was altered pituitary adrenal interactions with nocturnal asthma, that these blunted adrenal responsivenesses. So their adrenal gland function, coordination of when to release cortisol, especially throughout the night, controlling the rhythm, was completely disrupted. And remember, this whole lung adrenal axis is based on this relationship between the adrenal glands properly releasing epinephrine and cortisol to support the immune system, and then to dampen inflammation and support inflammation resolution. So one of the easiest ways to disrupt circadian rhythms is sleep dysfunctions and blood sugar imbalances. So there's plenty of research that's linking states of blood sugar roller coaster rides with hypoglycemia, with insulin spikes and glucagon spikes and leptin resistance to impacting expressions of asthma, and then not having enough cortisol release and proper cortisol rhythms for also the severity of asthma, since they can't bring the inflammation of the mucosal system down. Okay? So the problem is, you get people that have asthma, they have these altered adrenal axis pathways, and they get on glucocorticoids. So this was a study that was published. This was a systematic review of 31 studies looking at the impact of inhaled corticosteroids and cortisol suppression in adults with asthma. And they found that statistically significant cortisol suppression was evident at low dose inhaled corticosteroids and increased with dose. These results support the impact of inhaled corticosteroids on endogenous cortisol levels and underscore the importance of titrating inhaled corticosteroids to the minimum required to maintain symptom control. Or a better scenario, get them to the point where they're healthier, where they don't have this dependence on it. So one of the things you want to do as a clinician is immediately look to see if your patient with asthma has any blood sugar irregularities. The key symptom of blood sugar irregularity is they have symptoms after they eat. If they have fatigue after they eat, you're suspecting insulin resistance. If they feel better after they eat, you suspect they have hypoglycemia. The normal response is there's no change in how they function after they eat. They just are no longer hungry. So their blood sugar regulation will be another key factor you want to look at. We can go into much deeper dives in that with the Crohn's Institute Dysglycemia course. Now, when you're looking at these blood sugar relationships and these adrenal glands that are also co-involved with them, remember that these corticosteroids are starting to dysregulate the HPA axis and suppress cortisol output. And this is a shame in asthma because we have to have healthy adrenal medulla releases to support bronchodilation and healthy HPA axis responses and circadian rhythms to properly activate the immune response. We need healthy amounts of corticosteroids to really blunt inflammation and promote inflammation resolution. So when you look at asthma, which is characteristic of bronchospasm in the airways from an inflammatory response, we know there's environmental allergens that are involved. We know there's pulmonary permeability. We know the microbiome is involved, but here the key thing is that there's adrenal gland dysfunction or imbalance, whatever you want to call it, and dysglycemia, chronic dysglycemia is a key factor. So it's not going to be uncommon for you to see patients that have asthma, like especially children and even adults, especially teenagers, that just have this roller coaster ride of what they're eating. And as soon as they get their blood sugar stable and they don't have these fluctuations of blood sugar by eating more protein and more healthy fats and eating more frequently with healthy fiber-rich foods, that their asthmatic symptoms can change dramatically. You definitely want to look at the cortisol awakening response with your asthmatic patients and your respiratory patients in general. You want to see that cortisol levels go up in the first 30 minutes. It's called the cortisol awakening response. When you want to look at an adrenal salivary index, you want to see this cortisol salivary index response takes place. There's some significant degree of keeping inflammation down and immune system priming during bedtime, and then getting the HPA axis to function first thing in the morning. And then you want to look at their cortisol levels in the morning, and they should come down throughout the day. Like here you can see the patient represented as the solid black line. It should be right in between the green lines. And their levels of cortisol morning and after nighttime can be measured. And you want to make sure that they don't have an abnormal rhythm. So here you can see, for example, a scenario where someone has elevated cortisol throughout the day. Here you can see someone who's got a disrupted rhythm represented in red compared to the other ones. Here would be like a very low cortisol patient. Like this person here is not going to be able to calm down their inflammation that's in their mucosa. They don't have enough cortisol. There has to be some degree of endogenous cortisol production to dampen mucosal inflammation. This patient here with the elevated cortisol is not releasing cortisol at the right times. They're more prone to getting like weight gain, insulin resistance. Those things actually aggravate insulin resistance patterns. These are disrupted rhythms like here are going to cause roller coaster rides of glucose all throughout the day that are going to be mixed within like blood sugar levels being low, blood sugar levels being high. So they get like a combination of symptoms of like getting shaky, light, and irritable and fatiguing after meals. So those are the things you want to look at. Now, this is just a summary chart of all the different things that can take place between different types of cortisol responses. So if the cortisol awakening response is abnormal, you might clinically hear that they have a really hard time getting out of bed and they have to use like caffeine or exercise to get going. Altered cortisol rhythms, they'll just have the fluctuation of energy throughout the day. Elevated cortisol, you see that tendency towards insulin resistance. And low cortisol, you see that tendency towards like the hypoglycemia patterns. And then here's just a simple chart of, the key things you just want to make sure that the patient understands and you can work with the patient to help restore some of their adrenal gland functions as well. And then, obviously there's nutraceuticals you can use if you suspect their blood sugar symptoms are off. They need some adrenal gland support. B vitamins can be really critical. Using adaptogens to help regulate their adrenal functions can be very useful for those types of patterns as well. Okay, and then this is a diagram here that goes, okay, remove their triggers. Adrenal triggers are going to be this chronic dysglycemia lifestyle or overtraining, not getting enough sleep, and just too much corticosteroid use. So those are the variables you have to look at. Now, another key thing to know about asthma, besides the microbiome and blood sugar stability and adrenal function, are hormones. There's very strong relationships between hormones and the effects on asthma. So this paper that was published went through these great diagrams, and if this paper is included in your course materials, it was an open access paper, and they show all these different mechanisms of testosterone, estrogen, and progesterone represented as T, E, or P for different immune cells. So here you can see testosterone, estrogen, progesterone impacting dendritic cells in asthma, and estrogen impacting B cells, and so forth. And they also summarized the literature with this illustration here, and you can see the effects of estrogen, progesterone, androgens. The bottom line is you really want to make sure a person doesn't have deficiency of any of these hormones or they have any fluctuations. And there's also this involvement of asthma rates changing. For example, in childhood asthma, there's greater prevalence in men, but once boys develop into puberty and their testosterone levels go up, that has an anti-inflammatory effect on their mucosa. And then women in puberty are having these menstrual fluctuations. That puts them at increased risk for asthma. So as children transition from puberty, it goes from being male-dominant asthma to female-dominant asthma. And then it's female-dominant asthma for some period of time until they reach in their late 20s. And then it's, a little bit more males and females, but not to the changes that took place earlier in life. And here you can see this indication of things that have been shown to really impact asthma, like in females that have menstrual cycle irregularities or females that go into perimenopause and menopause. There is significant flare-ups of asthma and expressions of asthma. So you could have a person who had childhood asthma when they were 8 to age 12, and they started to slowly grow out of it. And then once they got into age 45 and started going through perimenopause, everything came back. Now they have asthma all over again. So those may be some hormonal relationships that are occurring. At the end of the day, what you have to do is identify a hormone imbalance and manage it to the best of your clinical skills that you know how to do. It's going to be different for each person. And then I'll skip this one here. Here's an illustration of something that's very common. It's just perimenstrual asthma. So it's very common for young women to develop asthma symptoms right during their early parts of their menstrual cycle, or premenstrual and right in the first few days of the menstrual cycle. Their hormone levels fluctuate in such a way where their mucosal respiratory system gets much more inflamed. They're more likely to have asthma attacks. And with a lot of these, women that have these severe menstrual fluctuations of hormones, they also have PMS and menstrual cramping. And a lot of times, you'll see they have prostaglandin imbalances and blood sugar issues that need to be managed. And if you look at the things we talk about, interventions we talk about in the hormone disorders course with PMS, premenstrual conditions, all those things would apply to strategies for premenstrual asthma. Now, when you look at the inflammatory pathways of asthma and hormones, don't forget prostaglandins or hormones. So a diet that's really high in butter and animal fat and is very low in things like PG1s and 3s like olive oil and fish oils and other things can also be a factor why some of the hormonal responses in asthma can be triggered as well. And that leads us into diet. But to really go into hormones, which is a key factor for certain people with asthma, you may want to look into the course we have in hormone imbalances throughout the lifespan. In that course, we go through a step-by-step process of evaluating endocrine imbalances and then looking at clinical strategies. It's a 12-hour course. Okay, so let's talk about nutraceuticals and what has the literature shown impacts asthma. So without doubt, one of the most clearly established nutraceutical supports for asthma is vitamin D. So this was a study looking at 10 randomized clinical trials. There's a meta-analysis of them. And when you summarize all the data and look at them as a single unit score, it's very clear that vitamin D supplementation can reduce asthma exacerbations, especially in children, and within 6 months of follow-up time. In addition, vitamin D has positive effect on improving the forced expiratory volume 1 of patients whose FE1 baseline value is less than 70%, but more randomized clinical trials need to support this conclusion. So that was the conclusion of the study. So they found out, looking at 10 randomized clinical trials, there was very clear indications that vitamin D really reduced the asthma exacerbation. Remember, vitamin D is not a vitamin, it's a hormone, has very powerful effects on the immune system. This was another study that was promoted on vitamin D that was not included in that meta-analysis that shows that it reduced severity of asthma, and it's a key factor, especially if patients are vitamin D insufficient. As a matter of fact, if vitamin D insufficient, the outcome is much, much, much better. There's been 40 studies that looked at different antioxidants and vitamins in this meta-analysis and review in this paper, and they said basically relatively low dietary intake of vitamin A and C are associated with statistically significant increased odds of asthma and wheezing. Now you'll see this common theme between the respiratory tract, like vitamin A is essential for the mucosa. So you'll see like in our fundamental treatment supports for different acute conditions and chronic conditions who have this mucosal support, you always see vitamin A in there. Say vitamin A, we mean like 10,000 IUs or higher daily to really support that mucosa. You see vitamin A in there and vitamin D. Those are like the two most important things that are very, very critical. C has also been found to have some effects on the immune system as well. If you want to look at this paper in Nature Reviews, it goes into the specific mechanisms of how vitamin A impacts asthma, and vitamin D impacts asthma, and vitamin C impacts asthma. But basically, you can see that it really modulates the dendritic cell responses that are involved, and they also enhance immune tolerance pathways, and vitamin D has a specific effect on the mesenteric lymph nodes and the dendritic cells as well. But basically, the key like antigen presenting cells of the upper airways, the macrophages and the dendritic cells there, are immediately impacted with vitamin A and vitamin D compounds. Okay, there's also studies that show antioxidants have a severe impact on the severity of asthma, and if you can, dampen the oxidative stress, it can have a significant role in modulating the expression of asthma attacks and the severity of asthma responses. So this was an illustration in the study that showed like oxidative stress, free radical activity itself can trigger the immune response that turns on IgEs and the whole mucosal response that then causes mucosal secretion, bronchospasm, smooth muscle contraction, all the things that are associated with asthma. So it doesn't always have to be like a food allergen or airborne allergen, just like free radicals can do it. And free radicals for some people could be when they exercise. That's why there's exercise-induced asthma. Free radicals for someone could be when their body gets into severe cold and hot environments where this turns on an inflammatory cascade and some of their own tissues start to respond to it, and there's a need for free radical responses and oxidative stress. So you can look at some of these papers, but there's very clear known pathways of how these free radical pathways promote asthma responses. And you can see even in this diagram, they show this balance wheel. It's this balance between having enough antioxidants versus reactive oxygen species for the severity of asthma and the inflammation in their mucosa, and then even further tissue damage. And really looking at how to balance that out with the amount of exercise that is good for them to turn on their antioxidants, but not cause too much free radical activity, is a key way to support children and individuals that have asthma. So that's another. So you'll see like lots of indications in the literature for using supplementation antioxidants. This is the paper that kind of reviewed all the different antioxidants: vitamin C, vitamin A, resveratrol, flavonoids. They all seem to have beneficial effects. I would say if you're really looking at the big picture of the respiratory system, you'll see N-acetylcysteine being so critical because N-acetylcysteine is a mucolytic compound, but it also converts to glutathione. As it converts to glutathione, it protects all the different barrier systems. And in its form as N-acetylcysteine, before it even converts to glutathione, it's also an antioxidant. So that would be on top of the list. And then I would say if you can add anything else to that list, like right away, like resveratrol is such a powerful antioxidant, that would be something to definitely consider as well. Okay. So there's some papers in your notes that go into those. There's also indications of zinc and selenium having some effects on reducing asthma risk. There's 26 studies in there. The bottom line is you don't want the person to be micronutrient deficient. You don't want the person to be vitamin D deficient. And you want the person to have antioxidant deficiencies in comparison to their toxic or inflammatory oxidative stress load. That's really the bottom idea. And this is another paper just showing when they measure the levels of glutathione levels, the less glutathione they had in their tissues, the more severe their asthmatic attacks were. So this is, pretty well known. And it doesn't even matter like what the trigger is. One study looked at mycotoxin-related compromise of glutathione. Other studies showed airborne allergens. Once glutathione levels get depleted, not only do you break the pulmonary barrier like we talked about previously, but you also but it also turns on the inflammatory cascade that impacts asthma responses. Okay, now let's look at diet. So the bottom line with diet is this: the more inflammatory the diet is, the more severe it is on promoting asthma flare-ups. And there's a direct relationship with the inflammatory index of foods with asthma and COPD risk. So you can see in this paper they looked at the odds ratio. They calculated what's called an inflammatory index, where they looked at pro-inflammatory foods and looked at maybe versus anti-inflammatory foods in someone's diet. This is something you can read in the paper if you have interest in it. But when they made a dietary inflammatory index, they found this very, very, very strong linear relationship between flare-ups and severity of asthma and COPD with dietary inflammatory foods. So diet absolutely makes a big difference. We all know this. But these, again, you can use many of these slides as educational tools for your parents that you're working with some of your patients that you're working with. That can be very helpful to get them to understand what needs to happen and also get them motivated. So the key things when you're looking at asthma, as far as what their mucosal immune system needs, from the very beginning, they really need healthy. They need breastfeeding. They need all the different substrates in breast milk that's not there in formula. They really need fatty acids in their diet. Micronutrients are really critical. Diet diversity is really critical, starting with the mother's microbiota and health. Now, this was a paper that was called Diet and Asthma Narrative Review. They went to the literature, look at various dietary factors, and in general, researchers found fruits and vegetable fiber, healthy fats were in dietary patterns considered high quality, appear to be beneficial to asthma disease. Meaning the amount of research on how healthy fats, diet, and vegetables and fibers impact asthma is of really high quality, and they should be considered when you look at treatment strategies. This was another paper that was published of 13,000 subjects, 19 to 64 years old. It's a 3-year study. And they found this significantly inverse relationship between consumption of fish, seaweeds, and the ratios of omega-3 and omega-6 fatty acids in Korean adults. Results suggested high consumption of fish, seaweeds, and foods rich in polyunsaturated fatty acids have a significant impact on asthma. So whether it's supplemental or dietary, it's really critical to dampen that inflammatory load. Here you can see examples in this illustration of, fish oils and olive oil being used to dampen the inflammatory pathways of asthma. This is an illustration that was published in Nature Reviews Immunology, where they go through and specifically show how like omega-3 fatty acids, these essential fatty acids dampen these macrophage and inflammatory-based pathways underneath the intestinal mucosa. And we're looking at patients' diets. Like with asthma, you got to see what kind of healthy fats and nuts and seeds they're eating. Now, what's happening right now in the world of the internet that's transforming into clinicians without having any critical ability to think is don't eat any foods with any oils with nuts in them. All nut oils are bad, because that is complete ridiculous nonsense. Like you see this everywhere now. Like people are completely avoiding like using flaxseed with their patients and other types of nuts. Nut seeds that are oxidized and processed for cooking, that's a bad idea. Like pure flaxseed oil, cold pressed flaxseed oil is phenomenal. It's published without any doubt that has anti-inflammatory effects. So this world of like internet and social media all of a sudden like bashing all seed oils has now transcended to clinicians, which you would think never would happen because they would be able to actually critically think and actually understand it's not the same thing, but it is happening, and it's a shame. So you can absolutely use things like cold pressed flaxseed oil and evening and black currant seed oil to have a very powerful anti-inflammatory effect with patients that have asthma. And you should actually look at their diet and see what they're low in. You may even want to measure with asthmatic patients a panel like this. This is an essential fatty acid panel, and get an idea of what's actually going on with their omega-3, 6, and 9 pathways. And if you need to use black currant seed oil or flaxseed oil to bump up one certain pathway, that'd be something you should definitely consider. The general concepts of an anti-inflammatory diet have been shown to be very effective in modulating asthma. And a lot of times, especially with kids with asthma, it's very obvious what you need to do. It's just figuring out how to create the environment, the parent, and their kid's lifestyle to make a difference. This was the paper that was published that's used sometimes where they go, there's no relationship between allergies and asthma. And you'll see some of these papers out there. And these are terribly, these papers are done in such a way where they're looking for a generalizability concept, so with very low sample size. So there's like no way to actually ever reach statistical significance because they didn't do a power analysis when they did their study design. Like just, how to say it, just terrible research. And then they'd find these findings like, yeah, we didn't find any potential relationship between cow's milk, for example, and asthma development. If you talk to any practitioner's practice for 3 hours, they will tell you hundreds and hundreds of stories of family members who've noticed significant reduction of asthmatic symptoms when they went off things like cow's milk. But you'll have like your typical allergist or pulmonologist just like refer to these studies, not really understanding that these studies are really too small of a sample size, but they're in the literature and they get referenced all the time. And in reality, in a real personalized lifestyle medicine practice, you're going to really want to also look at specific food sensitivities patients have, and then kind of adjust whatever diet that needs to be done based on other healthcare factors to look at their asthmatic responses. So combination of diets, like some people that have asthma and they're overweight and they have insulin issues, you might want to do like a ketogenic diet, and then also in combination with a microbiome diversity diet. You could have a patient, for example, that has chronic sinusitis with nasal polyps and RA and have an autoimmunity, and you have to control their autoimmunity to get their inflammation down. So they may be on an autoimmune diet with like lectin-free, nightshade-free, gluten dairy-free, and they may also need to be on a low-salt diet with a microbiome diverse diet to really dampen their inflammatory response and their mucosal response with asthma and so forth. Okay? And then as we get into some of the other key research pathways, trends, there's a bunch of papers in your course notes about fiber. And basically, fiber turns on short-chain fatty acids. And these short-chain fatty acids that are produced by bacteria in the gut that convert fiber to things like butyrate, acetate, and propionate, they bind to these G-coupled proteins. And these binding of these fatty acids, these G-coupled proteins, immediately and dramatically dampens inflammation within the respiratory system, and it really has a significant impact on asthma. So one of the most useful tools you can use dietary-wise for your patients that have asthma, in addition to like healthy amounts of essential fatty acids and high antioxidant foods, is fiber. Now, supplement-wise, you can just have patients take short-chain fatty acids. They can take like endogenous butyrate, propionate, acetate, and that can have an immediate effect when they're dealing with like asthma inflammatory reactions. There's a lot of relationships with obesity and asthma in the literature. As you guys know from some of our other courses, if you've been attending, there's lots of relations between body fat itself releasing inflammatory cytokines and inflammatory adipokines. These all have been linked to asthma. And they've also found weight loss dramatically impacts asthma-related inflammation. So it's one of the things you should definitely know about as a clinician as you think about your clinical strategy and your clinical protocols. So as we look at the summary of, as a clinician, what you want to kind of do with asthma is, first of all, make sure the diagnosis is correct. You have to have asthmatic symptoms plus a demonstration of expiratory airflow obstruction. Have the patient get at least a peak flow meter or a spirometer, and then have them measure their peak expiratory flow throughout the day and get an idea if you see any trends, what their baseline is, and see what things need to be done. Obviously, if asthma was simple as taking like a magic supplement, everyone wouldn't be one of the most common conditions worldwide. It's a condition where someone's mucosal health, their mucosal responsiveness that was developed over their childhood, their antioxidant status, their gut-lung microbiota, their adrenal lung access are all key players with this. See what kind of severity they have, go through history, try to identify any kind of triggers that may be involved, then sit down with the patient, Try to figure out what your clinical goals are. The reduction of intensity and frequency of asthmatic symptoms is important. Trying to identify and removing triggers will be important. Seeing if they can participate in normal daily activities will be important. And then go through all the key steps and processes. Ultimately, what you're trying to do is trying to improve the variables we talked about for pulmonary resiliency to reduce their flare-ups and their exacerbations. If you have a kid with asthma that continues their life taking a bronchodilator, they're going to have health consequences for the rest of their life. If you have an adult who has to use bronchodilators on a regular basis, they're going to be the ones that fall with a hip fracture and then don't recover. They'll be the ones that have spinal collapse when they're age 50 and 60 and they can't do anything physical and active anymore. And the way bronchodilators, the glucocorticoids, are handed on this population is shocking and scary. And the nonchalantness of healthcare professionals just talking about, everyone does it, it's just the way it is, there's nothing else we can do, is also very, very shocking. And when you see all this literature and how antioxidants and vitamin D and health of the microbiome and things like short-chain fatty acids can dramatically impact asthma, we have this huge deficit of what's in the literature that can easily be implemented, and what's in healthcare that is so biased that none of these interventions take place. And this is why one of the things I said is asthma is one of these pulmonary conditions where functional medicine practitioners shine with and really resolving and improving patients' quality of life with it. So those are the key things I wanted to focus in this lecture. And then we'll go into the next lecture, which should be review, putting all these things together, go through the evaluation process, and then how to prioritize the treatment plan. Thanks.